Hi class, our team, who includes Genesis, Diane, Margarita, and myself, Jennifer, will be discussing the prevention of mistakes in surgery, specifically wrong site surgeries, as it associates with the 2021 National Hospital Patient Safety Goals. Mistakes in surgeries are a serious and preventable adverse event that should never happen. Wrong site surgeries are devastating, unacceptable, and often result in litigation, with their root cause and frequency unknown, despite the implementation of prevention strategies and little evidence that current prevention practices are adequate. The following 2021 Hospital National Patient Safety Goals focus on the prevention of mistakes in wrong site surgery and include making sure that the correct surgery is being performed in the correct body location, marking the correct place of the patient's body where the surgery is to be performed, as well as pausing before performing the surgery to make sure a mistake is not being made. The improvement model begins with 3 questions. What are we trying to accomplish as it pertains to the wrong site mistakes in surgery? Our goal is to decrease the incidence of these adverse events within 2 years. And how will we know a change is an improvement? Well, we can identify a change is an improvement when the number of wrong site surgeries decreases. What changes can we make that will result in an improvement? Changes that are related to the improvement of wrong site surgeries include the implementation of a pre-procedural checklist, enforcement of the timeout step of the universal protocol, and marking the surgical site with an improved surgical marker. Our aim statement for our project is to reduce the incidence of wrong site surgeries among hospitals in the United States by 50% within the next 2 years by improving compliance of the universal protocol and the use of other supplementary tools and procedures. As W. Edwards Deming stated, if you can't describe what you're doing as a process, you don't know what you're doing. Although reporting is not mandatory in most states, some estimates put the national incidence rate of wrong patient, wrong procedure, wrong site, and wrong site surgeries as high as 40 cases per week. Even when considered sentinel events or events where the results lead to severe temporary harm and interventions to sustain life, permanent harm, or death, reporting of mistakes in surgery is not required and completely voluntary by health organizations. Information provided to bodies such as the Joint Commission is only a small portion of actual events, which puts into perspective how critical it is to implement the necessary procedures to improve the safety outcome and strive for zero harm. Between 1990 and 2003, of 236,600 malpractice cases reported to the Joint Commission, 2,217 were wrong body part surgeries. In addition, according to the Joint Commission, 113 wrong surgery cases have been reported in 2021 alone, as per the 2021 update on Sentinel event general information. Our PDSA process involves working with 4 cycles, including plan, do, study, and act, in order to implement a plan to improve wrong site surgery outcomes. Our planned portion of the PDSA cycle will consist of implementing a pre-procedural checklist, enforcing the timeout portion of the universal protocol, and the use of evidence-based surgical markers approved for surgical procedures. The do portion involves providing education training sessions on the pre-procedural checklist process, entering timeout and pre-procedural checklists into the EHR or paper chart if applicable, as well as providing the team with accessibility to evidence-based surgical markers. The study portion of our PDSA cycle will include compliance and observations of the staff. In the act portion of the PDSA cycle, we will evaluate the effectiveness of our changes and implement the changes, if progressive, to meeting our aim. Our first step in our plan portion of the PDSA cycle is to implement the use of pre-procedural checklists. Before the patient's departure to the operating room, the induction of anesthesia or any skin incision, we plan to implement a pre-procedural checklist that should be completed and signed off prior to occurrences of surgical events. We believe that providing staff with a checklist as a step-by-step guide to safe surgical procedures, we can reach our aim in reducing the prevalence of wrong site surgeries. The sign-off portion of the checklist should be completed with no interruptions, especially during the initial confirmation process with the patient. The checklist should then be double-checked with another nurse and the surgeon in the final step of the process. When co-signing, it is recommended the witness be a nurse from the surgical team. The sign-off section of the checklist will consist of ensuring that the patient has confirmed their demographic information, as well as a surgical site, procedure, and consent. If the patient is considered incapacitated or disabled, this portion of the checklist should be completed with the corresponding healthcare surrogate or proxy of the patient. This step in the process will also involve confirmation that the surgical site has been marked with an approved surgical marker and that anesthesia safety check has been completed with a review of the patient's current medication usage. Moreover, this checklist will also include a comprehensive history of the patient's most recent vital signs, allergies, risks associated with airway and blood loss, as well as previous surgical complications, if applicable. The timeout process is a critical part of the Universal Protocol established by the Joint Commission. By enforcing the practice of the timeout portion of the Universal Protocol, not only do we provide all active members of the surgical team with an opportunity to participate in the process, but by working collaboratively, we're able to take an additional step to prevent the incidence of wrong site surgical mistakes. Once the patient is in the operating room, the surgeon will call for a timeout, which at that moment, everyone will cease their current tasks and begin the timeout scripting. The timeout scripting will include verifying the correct patient, correct procedure, and correct site, along with verification of the surgical marking and its visibility with all members of the surgical team. Surgical markers will be introduced into the process of every surgical procedure to correctly identify the surgical site prior to the commencement of pre-procedures, including patient disinfection and bathing. The physician will add his initials near the anatomical or incision site, which will be used during the timeout process in the operating room as well. The surgeon's initials will be marked visibly with approved surgical markers to prevent inconsistencies and the possibility of breakdown prior to any procedure. The due portion of the PDSA process involves providing education programs that offer training to all healthcare professionals involved with the surgical team, including surgical team members themselves. Training sessions will include teaching of the pre-procedural checklist, information on the enforcement of the surgical timeout step belonging to the Universal Protocol, and the use of approved surgical site markers. Members of the healthcare team will be informed of the expectations of the pre-procedural checklist, timeout process, and surgical markers, as well as provided several means of communicating feedback and comments as they pertain to the changes and new processes. For the pre-procedural checklist, healthcare providers will be expected to introduce the checklist into the patient's EHR record, which will then be audited by the Quality Improvement and Risk Management Department. In order to ensure compliance, the pre-procedural checklist must be scanned within 12 hours of the patient's surgery or before the change of the shift, whichever comes first. The timeout sheet is to be entered into the patient's health record within 2 hours of surgery to ensure real-time data is made available for other members of the healthcare team and follow-up by the provider. In regards to the use of surgical marker, this tool will be made available in both the pre-op and surgical suite areas for use by the surgeon in a convenient and easily accessible manner. The study portion of the PDSA cycle involves collecting data on a daily basis and capturing the audited information in an Excel spreadsheet that will compare the total number of surgeries performed versus those that were identified as wrong site mistakes. As the quality improvement and risk management teams review pre-procedural checklists, they will be able to identify the total number of surgeries, any missing pre-procedural checklists that require follow-up and wrong site surgery mistakes. In addition to studying the results by auditing, the surgical team will be observed during the surgical procedures to ensure proper use of the pre-procedural checklist, the timeout step of the Universal Protocol, and the use of approved surgical markers. The last action in the study step of the PDSA cycle will be to compare the data obtained to our predictions by quantifying the errors and determining any trends in wrong site surgery mistakes. During the ACT portion of the PDSA cycle, we determined that the changes to reduce the incidence of wrong site surgery were effective and could be implemented. Modifications to the process were determined to not be needed so long as factors such as adequate staffing, the elimination of distractions during the pre-procedural checklist and timeout step of the Universal Protocol, role awareness during the timeout scripting, effective communication during pre and post-surgical interventions, accessibility to approved surgical markers, completion of the pre-procedural checklist, and timely documentation of the pre-procedural checklist and timeout step of the universal protocol remain constant. Within 2 years, we anticipate a reduction in wrong site surgical errors by 50%, potential barriers for success. Although a study found that 26 of 72 surveyed surgeons do mark surgical sites prior to their surgical procedures, we expect the use of supplementary tools and procedures, including the enforcement of the universal protocol, to reduce the number of these adverse events. In addition to the implementation of a pre-procedural checklist, we anticipate that the execution of the surgical marker and timeout step prior to and following surgery will aid in the decrease of wrong site surgical incidences. Potential barriers that would prevent the department from achieving a decrease in wrong site surgical incisions include low visibility of the surgeon's surgical markings after pre-op preparation, fast-paced environments or same-day emergency surgeries, departments requiring a daily patient quota, the department culture, insufficient staffing, and multiple procedures performed on one patient by different surgeons. The following images demonstrate the use of distinct surgical markers prior to the preparation of a surgical patient and following distinct skin regimens, such as the use of chlorhexidine, betadine, and a combination of both. In addition, we have provided an image that shows an example of the surgeon's initials at the surgical site. In order to sustain a decrease in the prevalence of wrong site surgeries, it is essential we ensure that there is enough staff that are properly trained in the implemented changes and that oncoming staff are competent in pre and post procedural steps. Other essential components include ensuring there is effective communication with management and administration teams in regards to the importance and safety of the patients, as well as updating the pre-procedural checklist as new improvements and suggestions are made. Additional factors associated with sustainability include completing and scanning the pre-procedural checklist in a timely manner, accurately conducting the timeout prior to the surgical incision, and providing annual training to reinforce importance of standardization. Moreover, routine equipment inspections, proper count of all surgical equipment before and after surgery, and using a dedicated surgical marker are other factors associated with sustainability. Lessons learned. The lack of communication among those involved in surgical procedures significantly affects the outcome of these surgeries. Lack of sufficient staff increases the risk of wrong site procedures from occurring, as well as lack of proper training. According to Cobb, the first line of defense is the preoperative verification process. By properly training all staff to verify and ensure the proper surgical procedure, mistakes can be prevented early on. Staff should perform cross-checks within the patient chart and verify the physician's plan for the surgical intervention. It is also imperative for the patient and their loved one present on the day of the surgery to be made aware as to which surgery will be performed and where the surgical site will be located, as a means of an additional measure to prevent an error from occurring. That is all for our presentation. Thank you very much.